Hello, today we will continue with the topic of cell dystrophies, and today we will be more specific. We will discuss disorders of protein, fat and glycogen metabolism. And we will start with proteins. As we mentioned before, those disorders can be subclassified as congenital or acquired. So it can be some inborn error of metabolism, or it can be something acquired, some acquired insult, for example toxic. And the storage can be intracellular or extracellular, or both. We won't talk, with regards to proteins, we won't talk about extracellular accumulations, because this is a slightly different topic. Amyloidosis is typical example, and we won't talk about it today. So today we will focus at the intracellular storage of proteins. How does it look like? Accumulation of proteins in a cell is eosinophilic, and usually it has an appearance of eosinophilic globules of various size, and sometimes it can be, let's say, less oval aggregate of hyaline material of eosinophilic proteins. The storage is usually in cytosol or rough endoplasmatic reticulum. Sometimes it can be intranuclear. And what are the causes? It can be increased reabsorption of the protein. It can be increased production. It can be accumulation of foreign protein. It can be clumping of damaged cytoskeletal protein. Or it can be conformational disease, which means that there is a problem with the folding of the protein. The sequence of amino acids is the same, but there is a problem with the folding of the specific protein. Typical example of increased reabsorption of proteins is or can be manifested as hyaline droplets in proximal renal tubules in patients with proteinuria. Common cause of proteinuria in adult patients is diabetes. Diabetic patients usually manifest with proteinuria, and in small children it is usually so-called minimal change disease, which is one of the examples of glomerulopathies, in which there is an impaired function of glomerular filtration membrane. And in those patients usually manifest with proteinuria. The proteinuria can be severe, especially for those children with minimal change disease. The proteinuria usually fulfills the criteria of nephrotic syndrome, and so there is a lot of protein in primary urine, and proximal renal tubules start to reabsorb those proteins. But they cannot process it because they are overwhelmed by the intake of the protein, and they start to store it in cytoplasm, and we can see it as a multiple eosinophilic globules. So here is the renal tubule, and the epithelia are stuffed with the multiple hyaline droplets because of the proteinuria. Example of increased production can be rustle bodies in plasmacytes. You can see it as those eosinophilic globules, again, in the cytoplasm of plasmatic cells, typically in dilated endoplasmatic reticulum. And this is usually seen in situations in which the plasmatic cells are driven to hyperfunction. So this is the overproduction of immunoglobulins usually. You can see it in patients with plasmacytoma, for example. It is very typical for plasmacytoma. Plasmacytoma or multiple myeloma, it's example of malignancy that differentiates towards plasmatic cells. So in fact, it's a type of lymphoma with differentiation towards plasmatic cells. And those malignant plasmatic cells are just crazy, and they produce immunoglobulins or fragments of immunoglobulins in huge amounts, and they just cannot expel it, so they start to store it in endoplasmatic reticulum, and we can see it as rustle bodies. But it is not just myeloma. You can see Russell bodies in other lymphomas, and you can see it in chronic inflammatory conditions as well. So if the chronic inflammation is severe enough, dense enough, you can see Russell bodies in those plasmacytes as well. So it doesn't necessarily mean that those plasmacytes are malignant. So you can see it in various autoimmune diseases. You can see it in allergic rhinitis, in hay fever. So generally, it tells you that the plasmatic cell is driven to hyperfunction. And we shouldn't forget that the viral capsid is a protein as well. So viral inclusions in affected cells is another example of storage of proteins. So in this case, it's accumulation of foreign protein. Not all the viral infections create or manifest with morphological visible inclusion, and not always the inclusion or the morphology, the appearance of the inclusion is specific for the concrete infection. But sometimes the morphology can be quite typical, and typical example is CMV, cytomegalovirus. Usually the cell affected by cytomegalovirus is enlarged. That's why this virus got its name cytomegalovirus, because the cell is large. The inclusion is usually intranuclear, and the nucleus is enlarged, and it has, let's say, smudgy appearance. And sometimes you can see, for example, here, sometimes there is a pale halo around the nucleus. And in some instances, the cell is binucleated. So you see a huge cell with two nuclei and pale halos around them. And to older pathologists, it resembled owl's eye. So if you see cell with the inclusion of the morphology of owl eyes, it's typical for CMV. And you can see it on this picture. This was a patient. This was transplanted patient. The patient underwent kidney transplantation, and after that, due to immunosuppression, the patient developed severe enteritis, the bowel inflammation, with blood in the stool, and histologically there were numerous huge viral inclusions in the cells. The CMV usually manifests in endothelial cells or stromal cells, fibroblasts for example. CMV inclusions in epithelium are not so typical. Or it can be accumulation of damaged cytoskeletal proteins. Typical example, Mallory-Denk hyalin or Mallory-Denk body in hepatocytes. Mallory-Denk body is nothing else than a precipitated, damaged cytokeratin or damaged cytokeratins from the cytoskeleton of the hepatocytes caused by toxic insult. Usually it's alcohol, so typically we can see it in alcoholic steatohepatitis. It is visible on this picture. This is liver with steatohepatitis. There is inflammation. There are another inflammatory cells. And you can see that the hepatocytes are damaged. They are swollen. We call it balloon degeneration. And in numerous hepatocytes, you can see those eosinophilic clumps, which is Mallory-Denk body or Mallory-Denk hyalin. And as I said, it's a precipitation of damaged cytokeratins caused by toxic effect of alcohol. And last but not least, there are conformational disorders. They are also called proteinopathies. In these diseases, there is a pathological conformation of the given protein with the predomination of beta-pleated sheet formation. So the sequence of amino acids stays the same, but there's a problem with the folding of the protein. Speaking generally about the conformations, the proper conformation of the proteins is ensured by so-called chaperones. Some of them are expressed constitutively, some of them are induced, usually by stress. Typical example are heat shock proteins induced by heat. The chaperones also ensure protein degradation. And apart from chaperones, the degradation is also managed by so-called ubiquitin, which marks the damaged protein, and then the protein is transferred to proteasome, and the so-called ubiquitin proteasome system or complex is created, and the protein is degraded. And what can cause the pathological conformation of the protein? It can be congenital. It can be congenital disease. It can be mutation of some gene of the protein that leads to misfolding of the specific protein. Typical example is alpha-1 antitrypsin deficiency. The antitrypsin doesn't work properly because of the pathological conformation, and it starts to store. The defect, the pathological conformation, can be also induced by something acquired, for example aging, simple aging, or toxic injury. Alzheimer's disease can be partially induced by this. The pathogenesis of Alzheimer's diseases is very complex, but just a piece of the pathogenesis, or part of the pathogenesis of Alzheimer's diseases, is also a conformational problem. We won't go into the details, that's a different topic. Or it can be inborn error of chaperones. Some neurodegenerative diseases or some cardiomyopathies are caused by this. And last but not least, it can be prions. Prions are in fact small infective particles that consist of proteins without DNA or RNA. There is no nucleic acid. They are just proteins which can be infective, and they act in a host body. In a host body, they act as chaperones. So they change the conformation of our own proteins that leads to various diseases. Again, different topic, this is just example. And what is the result of the pathological conformation? Well, first of all, the protein is not functional. It doesn't work properly. The protein cannot be enzymatically degraded and creates deposits in tissues. It starts to store. The protein can be toxic as well, even without depositions. And the problem is also that the protein is not immunogenic, which means that the protein cannot be attacked properly by our immune system, because the sequence of amino acids is the same, but there is a problem with the conformation. As I mentioned before, the misfolded protein can be also stored extracellular. Typical example is amyloidosis. Amyloidosis, you can see it here as those eosinophilic amorphous masses in the liver, and the hepatocytes are dying out in the amyloid. But amyloidosis is a different topic, and we won't cover amyloidosis today. So this was about the proteins as a whole, but there is a group of, but apart from that, there is a group of congenital defects of individual amino acids. So there are some inborn errors of individual amino acids. They are, let's say, marginal from the pathological point of view because they are usually functional. So usually there is no morphological change, morphological correlation, and those diseases are rather functional. But they are definitely not marginal from the clinical point of view because they are not so rare, and they can be very severe, and they are important. I think we should remember phenylketonuria, which is inborn error of phenylalanine metabolism, and the main clinical symptom of those children is oligophrenia. They are also prone to eczemas, cramps. They've got typical stinking urine because of the phenylalanine metabolites. And we should definitely remember that. We should also mention tyrosinemia, which is inborn error of tyrosine metabolism. And the main problem for those children is a liver failure. It's quite early liver failure, and those children also have a huge risk of hepatocellular carcinoma in this condition, in this terrain. So you can see hepatocellular carcinoma in very young children, in 2 or 3 years old children. Lipids. Don't be confused with terminology. The congenital error of lipid metabolism is called lipidosis. The acquired insult leading to storage of the fat is called steatosis. Again, the storage of the lipids can be intracellular and extracellular. In case of lipids, we will describe both because they are often combined. And lipomatosis is something slightly different. Lipomatosis means the increased amount of adipose tissue as a whole. You can see it in simple obesity or as in lipomatous atrophy. Lipomatous atrophy, very often you can see it in skeletal muscles, for example. If a skeletal muscle undergoes atrophy, it is often replaced by adipose tissue, by adipocytes. And we call this lipomatous atrophy. Or you can see it in pancreas. So lipomatosis is something different. It means increased amount of adipose tissue, but it is not storage of the lipids in the cells or extracellular. We will start with acquired disorders. How does it look like? If the steatosis is severe enough, the affected organ is yellow on gross examination, and in case of really extensive steatosis, the organ can be even enlarged and oily on the cut surface. Histologically, in case of simple triglycerides, they usually form droplets. They form droplets. They are usually small and multiple in the beginning, and later on they fuse and form one big droplet. You can see it in liver in this example. In case of liver, we tend to subclassify steatosis to micro and macrovesicular. Microvesicular means that steatosis consists of multiple smaller vacuoles, and macrovesicular means that there is a big vacuole. It has its diagnostic significance because the predominance of microvesicular steatosis in liver usually denotes more severe and rapid process. So if you see severe, almost purely or at least predominantly microvesicular steatosis in liver, it usually indicates some intoxication or congenital error of metabolism. So it's good to keep in mind. Complex lipids, such as glycolipids or sphingolipids, they have usual appearance of tiny, very small droplets, or the cytoplasm of the affected cell looks foamy. They have there's no tendency to fusion of the vacuoles, and they are often PES positive because very often there is a glycid component in the molecule. Electron microscopy can be useful in these situations. Because this is true especially for the congenital disorders, congenital inborn error of complex lipids, of metabolism of complex lipids. In these situations, you can very often see so-called lamellar bodies in electron microscopy, which means that those accumulating lipids tend to create something that resembles myelin sheath. This, for example, was the heart of the patient with Fabry's disease, which is an example of inborn error of lipid metabolism. Cholesterol has a tendency to create crystals, which is quite usual for cholesterol. It is shaped of small, slim, needle-shaped crystals, and quite often there is a foreign body reaction around the crystals. We should keep in mind that the fat is extracted during formal paraffin process. So those vacuoles, as we see, this is not a fat, this is just the empty space where the fat used to be. And if you need to stain the fat and, for example, differentiate or to tell that the vacuole is really the fat, not just the edema, you need a fresh sample for that. You need a fresh frozen sample, not formal fixed, and then you can use special stains such as oil red or Sudan black. What are the causes of steatosis? We can subclassify steatosis into several subgroups. Then we will start with resorptive steatosis. Resorptive steatosis means that there is an increased supply of fat. So in this case, the affected cell is usually okay, there is no problem with the affected cell, but the cell is overwhelmed by increased supply of the fat, and the cell just cannot process it, and it starts to store it. The supply can be systemic or localized. We will describe it in the next minutes. Retention steatosis means that the cell cannot process the fat due to its damaged metabolism. So there is some insult that cripples the cell, that cripples its metabolism, and after that, because of that, the cell cannot process the fat. We will start with the resorptive steatosis. Saginative status of liver. It is very common. It means increased consumption of fat. So if you eat too much, if you eat a lot, you become obese, and you also can develop very easily steatosis of the liver, as you can see on the picture. Or foie gras. It's a typical example of saginative steatosis from the pathological point of view. Those gooses are simply stuffed with a lot of food until they develop severe steatosis of the liver, which is considered a delicacy in some countries. Example of localized resorptive steatosis is simply put, cleaning of the purulent focus. Because if you have a purulent focus somewhere, for example abscess, there is a lot of fat. There is a fat from the cytoplasmic membranes of the dying cells, and also the neutrophils, which are essential component of purulent inflammation. The neutrophils usually undergo regression and they develop steatosis, and after that they will die out. So in purulent focus there is a lot of lipids, and when the purulent focus starts to heal, macrophages will arrive into this focus and they start to engulf lipids from the dead cells, and they became foamy. Their cytoplasm became foamy because they are full of fat, and they start to form clusters, and this is called post-inflammatory pseudoxanthoma. You can see it on this picture. This is inflammatory focus, and here you can see clusters of big cells with pale foamy cytoplasm, and those are macrophages that are stuffed with lipids. If the post-inflammatory pseudoxanthoma is bigger, you can see it even grossly as a small yellow spot. Another example of localized resorptive steatosis is cholesterolosis of gallbladder. This can be seen in patients with hypercholesterolemia, because cholesterol is a part of bile, and in patients with hypercholesterolemia there is increased amount of cholesterol in bile, and macrophages from gallbladder mucosa will start to engulf the cholesterol from the bile, and they will create clusters and depositions of foamy macrophages in gallbladder mucosa, and grossly you can see it as a small yellow spots, which is called cholesterolosis. Sometimes if the cholesterolosis is severe enough, it can also create a small polyps. We call them cholesterol polyps. Sometimes the polyp can be bigger, and it can let's say it can mimic neoplasm, for example on ultrasound. So sometimes the patient undergoes cholecystectomy because of the gallbladder polyp, and then we will find out that it's just a cholesterol polyp and not a neoplasm. If the patient has a cholecystitis in the inflammation of the gallbladder, the mucosa of the gallbladder is hyperemic, it's red, and then you see combination of red cytoplasm, and very often there is also cholesterolosis in form of multiple yellow spots, and to old pathologists and old surgeons it resembled strawberry. So this is called, sometimes it's called strawberry gallbladder. Another example of localized resorptive steatosis is encephalomalacia, brain infarction, stroke. There is a lot of fat in brain tissue because of the myelin. And in case of brain infarction, brain necrosis, the macrophages will start to engulf the necrotic tissue, which is full of fat. And you can see many foamy cells at the periphery of the necrotic focus in the brain. So during the healing of the brain infarction, you can see multiple foamy macrophages. And it is another example of resorptive steatosis. We shouldn't forget atherosclerosis. In patients with hypercholesterolemia, typically, or in patients generally with dyslipidemia, the deposits of the lipids will start to form in tunica intima of arteries from the bloodstream, and macrophages will start to engulf them, and they will create clusters of foamy cells in intima. So initially the atherosclerosis starts as intracellular steatosis, but subsequently, and you can see it here on the picture, this is tunica intima of artery, and here you can see multiple foamy macrophages. But later on, the extracellular deposits of lipids are formed as well. We call it lipid core, and around the lipid core there is a fibrous layer. We call it fibrous cap. So the larger, fully developed atherosclerotic plate has a lipid core and fibrous cap. And very often it calcifies. So the advanced atherosclerosis has a tendency to calcify. Here on the right you can see example of developed atherosclerosis. This paler region, this is fat, this is lipid core. You can see also cholesterol crystals in here. And this more eosinophilic layer, this is fibrous cap. So atherosclerosis is another example of steatosis. Xantoma. Xantoma can be quite often seen in patients with hypercholesterolemia, and xantoma means skin deposits of lipids which are subsequently engulfed by macrophages, and they create clusters of foamy cells in the skin, in dermis. And you can see it as a multiple yellow spots or plaques. Quite often it can be seen on eyelids, which is called xanthelasma palpebrarum. Another example is Archus senilis cornea. Archus senilis cornea is a grayish rim at the periphery of the cornea of the eye, which is caused by diffusion of lipids from the limbic vessels. And then we'll move on and we will talk about retention steatosis. We shouldn't forget that the cell can undergo steatosis not only because it's intoxicated by something, but very often simple hypoxia can create steatosis, and which is quite common. Typically you can see it in liver, for example, as a consequence of chronic congestion, chronic venostasis. Because if the organ suffers by chronic venostasis, typically in patients with right-sided heart failure, it means that the organ is also hypoxic, because venous blood physiologically is poor of oxygen, and in case of chronic congestion, the venous blood stagnates in the organ for a longer time, and the organ, so the hypoxia of the organ is prolonged here. How does it look like in liver? We shouldn't forget that in liver there is something called liver lobule. And liver lobule has a hexagonal shape. At the periphery there are portal tracts, and in the middle there is a central vein, and the blood flows from the portal spaces to the central vein. And during the flow of the blood, the hepatocytes take the oxygen. So even physiologically, this zone around the central vein is more hypoxic than this zone of hepatocytes near portal tracts. So any disease that is anyhow associated with hypoxia of the liver will be manifested mainly around the central vein. So even the steatosis will be manifested mainly around the central vein, and there will also be a hyperemia of the parenchyma. And later on, those hepatocytes around the central vein will undergo atrophy. The steatosis can diminish, and the steatosis will move towards the portal spaces. So the localization of the steatosis depends on the time frame and depends on the severity of the venous stasis. And as a consequence, grossly, those liver has a typical marbling, because there is a layering. There are layers that are more pale, which are steatotic, and layers that are less pale, which are less steatotic. And this typical gross appearance with the marbling of the liver, it resembles nutmeg on the cut surface to the, again, old pathologists, old surgeons. So that's why those liver are called nutmeg liver, or hepar moscatum in Latin. Also, the heart can be affected by hypoxic steatosis. It is not so common. It is less usual. You can see it in patients with chronic pulmonary diseases or congenital heart malformations. In case of heart steatosis of myocardium, you can see layers of myocardium which is more pale and more yellow, which is affected by steatosis, and then layers that are more brown, which are less affected by steatosis. And this layering of the myocardium, it resembled the skin of the tiger. So that's why such heart is called tiger heart. And tiger heart means hypoxic steatosis of myocardium. Another big group of causes of steatosis is toxic steatosis. It means the cell was intoxicated by something which disrupted its metabolism. Typical example, alcohol. Alcohol is toxic for hepatocytes and induce fatty change. So alcoholic fatty liver disease is typical example of that. Or amanita poisoning, mushroom poisoning, another example. Or various drugs like medicaments can induce liver damage, which is very often associated with steatosis. We should mention Reyes syndrome, which is a severe complication of aspirin intake in smaller children. And last but not least, there is so-called transportative steatosis. Transportative means that the steatosis developed as a consequence of disrupted transport of something. Some toxins or some infections can mobilize suddenly lipids from deposits from adipose tissue, which can lead to temporary lipemia, temporary increased amount of lipids in blood, and subsequent steatosis of organs. But maybe more, which is more common, is steatosis in patients with hypoproteinemia, because lipids are hydrophobic and they cannot circulate in bloodstream without proteins. So they circulate in bloodstream in a form of lipoproteins. And if the patient has a hypoproteinemia, such patient cannot create lipoproteins. So even the patients with hypoproteinemia are prone to steatosis of organs. And again, don't forget neoplasms, because the storage of fat in various neoplasms can be quite common. And also we can have tumors arising from the adipose tissue itself. We call them lipomas, which are benign, and liposarcomas, which are malignant. And we will proceed to congenital disorders of lipid metabolism. There are typical examples of lysosomal storage disorders. The mutations usually affect enzymes that are involved in catabolism of complex lipids, very often sphingolipids. And the storage is usually found in the CNS, neurons and other cells, and macrophages. Because of that, the clinical symptoms are mainly neurological or stem from damage of organs of reticuloendothelial systems, such as liver or spleen. Many diseases may manifest as leukodystrophy, which means disorder of myelination. And we will mention a few of them. First, there is a Gaucher disease. The inheritance of Gaucher disease is autosomal recessive, and this is disorder of glucocerebrosids, which are enzymes that cleave glucose remnants from ceramine. So there is a storage of those glucocerebrosids. The enzyme is active mainly in macrophages, which means that the mainly organs of reticuloendothelial system will be affected. Microscopically, we can find so-called Gaucher cells, which is a cell storing complex lipids, and it has typical morphology. It is not exactly foamy, but the cytoplasm looks more like it is called, or it is described as a folded cigarette paper. We can subclassify Gaucher into type 1 and then into neuronopathic forms. Type 1 manifests usually in adolescent or adult age, and the infiltration or damage of organs of reticuloendothelial system dominates here. There is a hepatosplenomegaly with hypersplenism, because if the spleen is enlarged, it has a tendency to hyperfunction. So those patients can be prone to thrombocythemia, for example, thrombocytopenia, for example. And there is also infiltration of bone marrow, which can lead to pathological fractures, pain, and sometimes the hematopoiesis can be reduced as well. Neuronopathic forms are more rare, they are more severe, they affect the young children, and there is also CNS involvement apart from liver and spleen. Another disease is Tay-Sachs disease, or sometimes it's called amaurotic familiar idiocy. This is mainly neuronal disorder. There is a storage of so-called GM2 gangliosids, mainly in neurons, and the disease usually manifests in small children. Very often they die around 3rd or 4th year of age. So the clinically neurological symptoms dominate. There is a progressive dementia, and there is a typical finding on retina. It is called cherry red spot. It is just relative transparency in fovea centralis, because in this fovea the retina is thinner here, so there is a lesser amount of lipid deposits. So it basically, this red spot means that this is the last region of retina that is relatively spared from the deposits. NiemannPick disease. NiemannPick disease can be again subclassified into two groups. First is type A and B, second is type C. Type A and B, there is a deficiency of sphingomyelinase, and those sphingolipids are stored mainly in macrophages, so this is mainly a disorder of reticuloendothelial system. And in type A, there is also a CNS involvement. Type C is something slightly different. Type C means that this is disorder of transport protein, transferring various lipids between lysosomes and cytosol. So there is a storage of various lipids like sphingomyelins, gangliosids, or even cholesterol. And the clinical presentation is quite variable. It can manifest in newborn age, it can manifest in adulthood. And mainly this is neurodegenerative disease. We should mention also Fabry disease. Fabry disease is X-linked disease, and the storage is multi-organ. But quite typically, it's stored in endothelial cells and vessel wall. So ischemic and hemorrhagic events are quite typical for Fabry. Quite characteristic clinical sign is burning of palms and soles. Very often, Fabry diseases is accompanied by cardiomyopathy. So the heart disease is very common in those patients. And sometimes it's more like a diagnostic sign than severe condition, but quite often Fabry disease is accompanied by multiple skin angiokeratomas, small tumors on the skin, which is called angiokeratoma corporis diffusum. And last but not least, we should mention some leukodystrophic diseases. For example, Krabbe diseases or Krabbe-Globoid leukodystrophy. It is mainly neurological disease with progressive leukodystrophy. And why globoid leukodystrophy? It's because the macrophages that store the lipids are very often multinucleated and somehow globoid. So that's why this disease is called globoid leukodystrophy. And we should also mention metachromatic leukodystrophy, which is again mainly a disorder of myelination. And at the end, there are disorders of glycogen metabolism. We can see storage of glycogen, deposits of glycogen in patients with both congenital and acquired disorders of the glucose metabolism. And the storage is usually cytosolic. It can be lysosomal in some instances. It is typical for some congenital disorders, but usually the glycogen is stored in cytosol. And microscopically, it's apparent as empty vacuoles or completely clear cytoplasm, because glycogen microscopically is completely clear. We can stain it with PES staining, because PES stains sugars, but in hematoxylin eosin, it's apparent as empty vacuole, or the cytoplasm can be completely clear. You can see it on this picture. You wouldn't guess it, but this is myocardium. This is heart muscle. And it was small child with glycogen disorder called Danon's disease. And as you can see, the cardiomyocytes are completely pale because they are stuffed with glycogen. A few notes about the acquired disorders. Typical example are glycogenated nuclei in hepatocytes. You can see them here as completely pale and enlarged nuclei. And this is not nuclear inclusion. This is in fact a pseudo-inclusion. This is a bulging of piece of glycogenated cytoplasm into the nucleus. So in fact, it's a pseudo-inclusion. And you can see it in patients with hyperglycemia, for example, diabetic patients. It can be seen in several metabolic disorders such as Wilson's disease, but it can be induced by simple infusion with glucose. Another example, which is more historical, let's say, is Armani zone or Armani Epstein lesion. It is not so common in these days, but we could see it in patients with glycosuria. Usually, these were patients with severe diabetes. And Armani zone means storage of glycogen in cytoplasm of proximal tubular epithelia due to glycosuria. So it's something similar to hyaline droplets in proximal renal epithelia in patients with proteinuria. And in this condition, the proximal epithelia are pale because they are stuffed with glycogen. And again, we should remind ourselves that several benign and malignant tumors store various substances, glycogen included. Typical example is clear cell carcinoma. Clear cell carcinoma got its name because the neoplastic cells store glycogen, and because of that the cells are very pale, almost empty looking. Clear cell carcinoma is typical malignancy of kidneys. It's the most common primary kidney malignancy, but you can see them also in different localizations. And we will end this lecture with congenital disorders of glycogen metabolism, so-called glycogen storage disorders. There is plenty of them. We will mention 5 of them. and they can be subclassified into liver and myopathic forms. Liver forms present mainly with hepatomegaly, liver failure, and those patients are prone to hypoglycemia because they are unable to produce glucose from the glycogen. The myopathic forms manifest usually by muscle weakness, especially after exercising, and by lactate acidosis. The heart is very often affected as well. So those patients are prone to cardiomyopathy as well, because this is striated muscle as well. Type 1 glycogenosis, or von Gierke's disease. It's a hepatorenal form, so the liver and kidneys are usually affected. It's a deficiency of so-called glucose 6-phosphate enzyme. Type 2, or Pompe's disease. This is example of lysosomal disease. So this is example of lysosomal storage diseases. The other glycogen storage disorders are cytosolic, but this is lysosomal one. There is a deficiency in so-called acid maltase or alpha-1,4 glucosidase, and it can be subclassified into infantile and late onset form. The late onset form manifests mainly by skeletal myopathy. The skeletal myopathy predominates here, especially in proximal muscle groups. The infantile form that manifests usually in newborns or very small children manifest by skeletal muscle weakness as well, with respiratory distress because the respiratory muscles are affected as well. Very often there is macroglossia. But those children also manifest with cardiomyopathy, which is quite typical feature for infantile form. The cardiomyopathy is not so severe in late onset form, but in the infantile form it's quite typical. Type 3, or Forbes disease, there is especially the liver damage. In type 4, so-called Anderson's disease, this is also mainly hepatic disease, and there is a deficiency of branching enzyme. So in this situation, the glycogen molecule is very long and it resembles pectin. And type 4, or so-called McArdle's disease, this is mainly a myopathic form. So there is especially a skeletal muscle weakness, and this is deficiency of muscle phosphorylase. And this is last information. There's also a group of disorders of monosaccharide metabolism, and this is similar to disorders of amino acids. Those diseases are mainly functional. There is usually no morphological visible storage of any substance, and we should mention galactosemia. Galactosemia is impaired degradation of galactoses to glucose, and those patients usually manifest with accelerated liver cirrhosis, CNS damage, and accelerated cataract. And that's all. So thank you again for your attention, and see you later. Bye bye.